So I see the doors are closing. So that means that we are at the second part of today's talks, and I'm really fortunate to give the talk now. So my talk is about physiological CTG interpretation to improve newborn outcomes, and this is part of my PhD research. I have no results from the project that we have, but I think it would be really nice as well to show you what we do at the Amsterdam University Medical Center, and also some preliminary results that I have so far. So my name is Aimée. I'm a medical doctor and a PhD student. I work full-time in a clinic, and that means that I have also the opportunity to see CTGs in real time and also experience how it feels like to make your clinical decision on CTG based on what we have now in the labor world. And these decisions are sometimes quite challenging. So it's nice to also do research about that. So I think it's always nice to see who I work with. So I work with two clinicians, obstetricians from the Amsterdam University Medical Center, Christian de Groot and Petra Bakker, and also Antonia is in my PhD team. And I think I also wanted to show this slide at the beginning. I think if we look at fetal monitoring and improving fetal monitoring, we have the technological aspects about improving the technology, but also the clinical point of view is very important. I have no patients in my PhD team, but of course as a clinician you always take into account patient perspectives as well naturally in your work, but I think the three things are very important when you look at innovating and improving healthcare, and then specifically in this regard fetal monitoring. So I'm happy that my team covers clinical perspectives but also technological perspectives. I'm really happy about that. So I first want to give you a bit of context before I tell you a bit more about the project we do. So I think it's a lot of things are already, I think, known, but I would like to tell them anyways. So worldwide, we see that the number of cesarean sections is increasing, and currently 21% of the babies are born with cesarean sections, which is almost twice as many as in 2000 when it was 12%. And this increases the World Health Organization's recommendation to have about 10 to 15% of babies born with cesarean section, because it not only has risks for babies and mothers, but also future pregnancies. And on top of that, what we see with the increased rise of cesarean sections, we also see that more elective cesarean sections are being performed, so the rate keeps on increasing, but also the increase in healthcare expenditure is very important with that regard. So it's not only healthcare risks, but also the risks for costs. At the moment, when you look at during labor, what are the most common causes for a non-elective cesarean section? It's related to progress during second or first stage of labor, about 20%, but more often we see suspected fetal hypoxia based on the CTG. And there's a different group as well. We see cesarean sections based on the wish from the mom, but also financial incentives that in some countries with private healthcare you see that cesarean section could be more preferable than vaginal delivery. If we then look at the rise in cesarean sections, and that it's suspected fetal hypoxia based on CTG is one of the drivers for that. It's also important to note that what we want to do with CTG is to prevent also adverse outcomes. But every 35 seconds worldwide, one baby does not importantly survive labor due to severe oxygen deprivation and the consequences of that. And we have also CTG in the labor ward to monitor the babies and to help improve the outcomes. And we also see that in the group of babies that is affected by severe hypoxia during labor, resulting in, for example, stillbirth unit deaths or severe brain injuries, that perinatal audits and national labor reviews show that more than half of these could have been prevented with better labor care, and CTG is a very important element of that as well. So we have shortcomings in fetal monitoring, which I mentioned have been identified as an important source of preventable harm in the labor ward. And part of that is because the clinical guidelines focus on pattern recognition. And I showed 2 examples with the fecal guidelines, but sometimes clinicians use like tools like the field chop to distinguish the different decelerations and then base a decision on that. Overall, we see that it results in increased intra and inter-observer variability, but also an increased false positive rate and a poor sensitivity. And in the end, we have more cesarean sections without the benefits for the baby, so less neonatal death or better long-term neonate outcomes. Although we do see less stillbirths and less seizures. So what we, you don't see the click through. That's but I had some really nice that you can just click through and then you see the different traits. Anyway, so what we know with CTG, we are good in 2 things. We know how to identify the healthy fetus. Well, we see it on the left side, and we are quite well in identifying the fetus that's preterminal. So we have the bradycardia, or the below the baby that has no baseline and has a very increased variability and tachycardic, and you're very worried about the baby, you do cesarean section. So we know these 2 groups really well, but all the others are the ones that we have difficulties in the labor ward saying something about them, what we think is their health. So that group is marked by significant intra-observer variability, and I hope with my PhD program to help clinicians help clinicians better understanding which baby is coping well with labor, which baby is not, and how to navigate through all that. So when we look at physiological CTG interpretation, we aim to help the clinician understand which baby recovers from the decelerations. Like Marianne also explained in her talk, every labor, every contraction has gives some hypoxia to the baby. So hypoxia during labor is common, it's normal, but it's about how the fetus copes with that. If the fetus has less reserves or the placenta is less sufficient, the baby might react differently to the intermittent hypoxia during labor. So with physiological CTG interpretation, we aim to make different groups. We don't use the FIGO guidelines, but we try to group them into which baby has gradually evolving hypoxia but still compensating for it. Which one is decompensating, so loses the recovery after the decelerations. And then which baby is showing more subacute hypoxia, so a rapid fall expectedly in the pH, for example, due to many contractions that do not allow the baby to recover between them. And then the acute hypoxia, which I think we can quite well already see in the labor ward, the preterminal ones, where you have a sudden drop in fetal heart rate, which then you should think about also sentinel events, acute events like umbilical cord prolapse, but also maternal hypotension, and also again the increase in too many uterine contractions. So with that, the team that I work with, so I do this research work with, I'll show you a slide in a minute, but Susanna Pereira, Petra Bakker, Per Olofsson and David Wertheim. And the team in Kingston, Susanna Pereira, she developed 3 decision trees. It's actually based from, they started the initiative with using STAN as well. So the first tree is, when do you connect STAN? And it's appropriate to start STAN, but we look, and I'll show you in a little bit, into the second one, which is how do you assess CTG without STAN on an hourly basis or when changes in CTG occur. So this is to navigate clinicians applying the key elements of physiological CTG interpretation based on the previous categories. So we have two projects that I'm currently working on. One is what we call the Back to Basics study, which is to assess the reliability and observe agreement of that new physiology-based classification format. And so the other study I will, in the PowerPoint, then the image falls away and you see another study. But I'll come to that in a minute. So as I mentioned, the team, it's a follow-up study on the first study. It's the study where the STEN is about when you assess the baby during the first hour of labor to see whether it's fit for labor, using the tree and then deciding whether you should connect stun or start stun or not. And in that study, we saw that if you compare the tree, so the fast and vertical tree, to FIGO guidelines, we saw the proportion of agreement for FIGO to not start stun was 74% and to start stun 47%. 74%, I'm sorry, and with the decision tree we saw the proportion of agreement to not start stun was 60 and to start stun was 70, which then gives the kappa agreement of 0.50 for the FIGO guidelines and 0.57 for fast and vertical trees. Not significantly, and that's important to say because you see that the confidence intervals overlap. But we were very interested to see how it's not with stun, because we didn't use stun in Amsterdam, and also to help clinicians during labor to make decisions about the classification. So we have a retrospective exploratory study where we ask expert obstetricians to rate 40 traces, 10 with adverse outcomes defined as pH below 7 and EPCA score below 4 at 5 minutes, and 30 traces with normal outcomes. And they use the last 2 hour traces, and the reason to do that is because we wanted to use the tool when we expect most changes as well in the CTG. So we use this part of the tree, so the second one that I presented earlier, and then you see that the clinicians are guided through questions based on how much time is spent on the baseline, what the variability is, if there's an increase in baseline, and how the labor is progressing. And it gives you a intervention to a suggested intervention. The interventions are, if you can see, mostly based on reducing fetal stress, so improve the fetal resuscitation. So, for example, if there are too many contractions, reduce contractions, or stop oxytocin. I mean like that. So that's what we do with the Back to Basics study. We divide it in 2 different rounds, and the clinicians that we ask to assess these traces then review them, and they provide whether they would have intervened or not, and also based on what they saw in the CTG. So it's quite we get a lot of information about how they look at the CTG, which aspects they find important, if it's baseline, variability, decelerations, accelerations, and if they would intervene, what would they do? Deliver, stop the oxytocin, things like that. So it's quite a thorough questionnaire that they also get with that. Then the next project that we're currently working on, it's quite in its early stages, but I think it's quite nice as well, is the study where we look into CTG characteristics in babies with meconium aspiration syndrome to improve the interpretation of babies with suspected chorionitis. We base this, we have an hypothesis that in the group with babies with meconium aspiration syndrome, we have babies that had thick meconium or meconium, and they got really sick afterwards with meconium aspiration. And we are very interested to see if this is an hypoxic-driven process, an infection-driven process, or is there something else that was was making these babies sick. Just an example of a CTG that I think is reflecting the thoughts is that if you look at this CTG, it's a primiparous woman for 41 weeks of gestation-induced labor, and the baseline starts at 128. And if you look at the top, it's the first hour that we see of the baby's trace, so it's a stable baseline. This is to 1 centimeter per minute. No, sorry, this is 2 centimeters per minute, so it's the Dutch tracing. And you see that it's stable. Then after 5 hours, you see a slight raise in baseline, and then, in the last hour before delivery, you see that the baseline has increased to 180, and you also see periods of increased friability, and we call those zigzag. I know that in terminology there was a recent paper to avoid these kind of definitions, but with zigzag we mean a saltatory pattern that's for a brief period of time. So if you look at the fecal classification, saltatory pattern is pathological abnormal, it's more than 30 minutes. We wanted to define it like a shorter period of time, and then we call it zigzag, but you should actually say it's increased friability. Then when we look at CTG characteristics, and we defined multiple characteristics like baseline, increase in baseline, prolonged decelerations, are the signs of gradually evolving hypoxia, subacute. When we tick for every trace of this group, which is 53 cases, we identified 4 groups. One that seemed more hypoxia driven because they have more decelerations. So they were more fitting the trace that I showed previously with gradually evolving hypoxia, either compensated or decompensated. And you see in that group that the increase in baseline was 2.5%, and 16 or 17% had a zigzag pattern. When we looked into the other group, where we think is more infection driven, the increase in baseline was 20%, and almost all of them, 19 out of 20, had that zigzag pattern. We also had a smaller group with acute hypoxia, with a baseline increase in 8.9%, but also some zigzag patterns in 40%, and a group with other that had a combination of the 3. So we were not sure about that group yet. So these are very preliminary results. I hope to share some more in a paper or next time. And that was my overview. Thank you for listening.